good. So I'll go ahead and get started. So welcome everybody. My name is Pam Kunz. I am a GI medical oncologist and I focus on the care of patients with neuroendocrine tumors. And it is really our pleasure tonight to do a special patient-focused event. We call them Smilow Shares, Understanding NETs, New Treatment Advances and Innovations. I have some exciting news. So this is also timed. This event is timed with NET Cancer Awareness Day, which is tomorrow. And we just got news that Connecticut has officially acknowledged this day in the state of Connecticut as NET Cancer Awareness Day. And what's also really exciting, and this is through advocacy work through the Carcinoid Cancer Foundation, that the large majority of the United States, including Puerto Rico, has also acknowledged NET Cancer Awareness Day officially on November 10th. So I'd like to just briefly introduce our speakers. We are going to go in this order. So I will be speaking first on NETs 101 and basics of treatment. I'll also moderate a Q&A. Dr. John Kunstman, an assistant professor of surgery, will be speaking about surgical management of NETs. Dr. David Madoff, professor of radiology and interventional radiology, will be speaking about liver-directed treatment. Dr. Darko Pucar, associate professor of radiology, will be talking about imaging of NETs. And Dr. Mariam Aboian, an assistant professor of radiology and nuclear medicine, will be speaking about theranostics and peptide receptor radionuclide therapy. So we will start with the basics just to get everyone on the same page in terms of background and nomenclature and some basics of treatment. So I'd like to start with a slide that I think is actually incredibly hopeful. It is a timeline of development of new FDA approvals in neuroendocrine tumors, which are along the bottom part of your screen, and also imaging approvals. And in the last decade, we have seen just an explosion of research in neuroendocrine tumors. And we've had 7 new FDA approvals in a number of different disease indications: pancreatic NET, lung NET, GI NET, carcinoid syndrome, and 3 new imaging modalities that have also been approved. So I'd like to start with a little bit of history. I always find this interesting. So some of you may have heard of the term carcinoid. It's actually a German term that was coined in the early 1900s by a German pathologist, Dr. Oberndorfer, whose picture is there on the right. He described this cancer and meant that it was, quote, cancer-like. I think he contributed a great deal to the field and really started some of the research in this area, but it was a misnomer. We now, in fact, know these are cancers and they are coded as such and treated that way. We'll speak about more of that later. NETs can start throughout the body, called the primary site. That's where they originate, and they most commonly start in the GI tract and the lungs. NETs are rare by incidence, meaning the number diagnosed per year, but are more common by prevalence, meaning the number of patients alive at any given time. Most grow slowly in comparison with their adenocarcinoma counterparts. Adenocarcinomas are the more common type of GI cancers, like the run-of-the-mill colon cancer or run-of-the-mill pancreas cancer. And somatostatin receptors, which many of us will touch on, is a special receptor on the surface of neuroendocrine tumor cells, and they're usually present on the surface of most NET cells. This is a little bit of a busy table. I want you to focus along the left. These are what I consider key patient characteristics that impact treatment. We're going to spend a few moments on some of these. Hormone status, extent and burden of disease, that's really the stage, grade and differentiation, pace of growth, primary site, and SSTR means somatostatin receptor status. So let's talk a little bit about hormones. Some of you may have heard the terms functional and non-functional. Well, functional means that we have symptoms from hormone excess, a measurable hormone in the urine or the blood, and then patients have true symptoms that are directly attributable to that. Carcinoid syndrome is a classic example of that. Happens in only about 10% of patients with small intestine NETs. In the picture, you can see flushing on the cheeks and the nose that is classic for carcinoid syndrome. Pancreatic NETs also secrete hormones, insulin, gastrin, glucagon. For example, if a patient secretes insulin, that can cause low blood sugar. It's more common to have a non-functional NET. So for this, it's patients who are asymptomatic or their symptoms are not from hormone excess. Let's also talk about the difference between stage and grade. This can be kind of confusing. So stage, I think of where is the cancer in your body? What is the extent of disease? We usually define this based on something called the AJCC staging criteria, and that uses a scale of stages 1 through 4, and it depends on things like tumor location, size, lymph node involvement, and metastatic sites. And here you can see, these are two pictures, Dr. Aboian will go through this later, of a gallium-68 PET scan. And on the left, in the middle is a pancreatic net, and on the right is a patient with a pancreatic net that is spread to the liver. Now, grade, on the other hand, is what do the cells look like under the microscope? So we don't have a pathologist on our panel tonight, but they are a critical member of the team. They look at the cells and can tell us, is it low grade or slower growing, or high grade and faster growing? And these are primarily based on two features. One is called the Ki-67 and another mitotic index. You may see those in your pathology reports. Those are markers of proliferation. And as of 2019, the Digestive World Health Association classification break NETs down into grade 1, 2, and 3, and well differentiated and poorly differentiated. Primary site matters. We used to lump all NETs together, but we now know that they need to be researched and often treated in different ways. So I gave some examples here of where NETs can originate. As I'd mentioned earlier, small intestine is one of the more common sites, and many treatments are tailored based on primary site. It's probably worth mentioning that if you know someone that has a NET that has spread to another place like the liver, you don't also have liver cancer. It maintains the properties from where it started. So it would always be called, for example, a pancreatic NET, but that has spread to the liver. This is another theme that we will touch on. Dr. Aboian will touch on this as will Dr. Pucar. So somatostatin receptors are the perfect target. So my cartoon here, in green is the somatostatin receptor. Imagine you have a large population. You want to figure out who has the somatostatin receptor. You do a gallium-68 PET scan. You select out those patients that have the somatostatin receptor. And then let's say you have a therapy that targets that receptor. Using the same target for therapy and diagnostics is called theranostics. And we actually have a way, I'd like you to just think about and try to remember this lock and key analogy. So the lock is the somatostatin receptor. The key attaches to that lock and drags along with it a radioisotope that we can use for imaging or for treatment. These are general treatment categories for NETs. We're not going to go into all of the details here, but somatostatin analogs, biologics, chemotherapy, and peptide receptor radiotherapy are the four main categories. And what I'd like to do is just walk you through a little bit of a treatment algorithm of how we think about selecting therapies for patients. So this is a little bit busy, and on the next slide, I'll give you a reference and we can make that available in the chat. So the NCCN, or National Cancer Network, is a guideline that physicians follow, but they also have a patient-facing guideline. And we have treatment algorithms that are based on primary sites. So this is an example of the lung guidelines. This is an example of pancreas, and I'll just walk through this one. So often we will start with either observation or octreotide or lanreotide. I should mention, by the way, that this is for patients with metastatic pancreatic NET. Subsequent therapies could include everolimus or sunitinib. These are both pills. Capecitabine and temozolomide are both types of chemotherapy. They're also pills. 177 ludotatate is the PRRT that Dr. Aboian will speak about later. These are not listed by number. And so what that generally means is that we tailor the treatment to a specific patient based on how the patient is doing and what our goals of treatment are. So for many patients with metastatic NETs, our goal is disease control, and many of these agents can achieve that. There are some that can also achieve tumor shrinkage, and that's a conversation depending on symptoms of the patient and what we're trying to achieve. This is the link, and again, I will put this in the chat. It's a great patient lay-friendly guideline on these NCCN guidelines. Small bowel is also an example. So I'm just going to end with a few parting thoughts. Whether you are newly diagnosed or have been living with your NET for a while, I want you to focus on understanding a few key basic principles. If your oncologist has not gone over these with you, please ask. These are good questions to bring in. Hormone status, what is your stage and grade? What is your primary site? And do you have presence of somatostatin receptors? I'd like to leave you with some really positive thoughts. So we've made so many advances in the last 10 years in terms of treatment and imaging. Academic centers like Yale will have clinical trials. We will always talk to you about what clinical trials are available and what standard of care treatments are available. And clinical trials are really the way we make progress, and they are definitely reason for hope. So I am going to stop share. I'm going to pass the baton to my colleague, Dr. John Kunstman.
Hello there. Can you guys hear me?
Yes.
All right. See my screen?
Not quite. It still looks dark, but maybe it's just thinking. There we go.
There we go.
Yeah.
Oh, okay, let me see if I can get my. All right. Can you see it still?
Yes, perfect.
All right, good. So good evening, everybody. Welcome. And thanks to the Cancer Center for organizing this and asking me to speak. I'm going to go pretty quickly because there's a lot to talk about with neuroendocrine tumors, and a fair bit of the treatment does involve surgery. So I'm going to try and give a very top flight overview and some examples. I will tell you there are some pictures of surgical procedures and specimens on these slides, not right away, but a little bit further. So just a forewarning, and I'll try and remember to point it out before I get to those slides. But if anybody might want to turn off their monitor and just listen in if you don't want to see pictures from say an operation, you may wish to do that. So without further ado, for this portion of the conversation, a few quick objectives. We want to talk about what are the indications for surgery. In other words, why would we take somebody to surgery for a neuroendocrine tumor? Really a big focus, and I think Dr. Kunz already alluded to this, is that every case really requires an individualized approach. And there may be some times where folks with even a localized neuroendocrine tumor can forego surgery, and we'll talk about an example of that. Then we'll talk about what does surgery entail, what are some options, and we're going to focus really on pancreatic neuroendocrine tumors and small bowel neuroendocrine tumors as sort of the broad example, most common examples of those that are approached by surgery, and then talk briefly at the end about what role surgery can play in metastatic neuroendocrine tumors. So just starting with pancreatic neuroendocrine tumors, as mentioned by Dr. Kunz, the biggest top level classification for pancreatic neuroendocrine tumors is whether they're functional or not. In other words, are they secreting hormones? And that also tells us not only how the symptoms present, but also sometimes how they behave. And some can behave in a more indolent manner, like insulinomas. And in the past, because virtually everybody with a hormone oversecretion would have symptoms, this is how people were diagnosed. But nowadays, non-functional neuroendocrine tumors, depending on which paper you read, it can be almost 3/4 or more of patients these days are diagnosed with non-functional PNETs, and they're diagnosed incidentally. They can still have symptoms, though, if that PNET is large enough to cause pain, nausea, or sometimes even jaundice. So here's an example of a CAT scan, and we're not going to do much imaging because we have some real experts later in the talk, but that's a pancreas on the CAT scan if you've never seen one before. And it's an important tool that we use to stage or determine where in the spectrum of grade and extent of disease each individual patient lies. So, we want to characterize the tumor, and you can see the tumor there with the yellow arrow on it. It's actually very easy to see neuroendocrine tumors of the pancreas because they do take up that IV contrast so well and are so bright. And we use some other modalities, including nuclear medicine, MRI, and sometimes endoscopy to stage and make the diagnosis, and also a number of blood tests for both tumor markers and hormones if needed prior to coming up with a treatment plan. Again, all these things can create small but sometimes very important and critical differences in how we go about treating patients with surgery. Kind of a theme of the talk is just that individuality. Like I said, if there are metastases, I think the good news is, and this was already alluded to as well, is that there are treatment options, and there are many treatment options. They're evolving and they're growing, and sometimes surgery can be used. For a localized pancreatic neuroendocrine tumor, surgery is really the primary modality for treatment. All functional neuroendocrine tumors, in other words, those that are secreting hormones, should be resected in patients that are good candidates for surgery. And patients with non-functional neuroendocrine tumors of the pancreas, if they're symptomatic, causing those jaundice, abdominal pain, those kind of things. But what about patients with incidentally discovered neuroendocrine tumors? For localized disease, in other words, non-metastatic disease, the biopsy and staging tests can really help to guide our behavior. So what are some things that could make us think that perhaps observation and no surgery might be the right way to go for a pancreatic neuroendocrine tumor? Well, if we see one of those lower grade lower grade tumors that have no lymph nodes that are enlarged, that are suspicious for early spread, and very small tumor size. So it's important to remember that all PNETs do have the potential to grow and spread. All of them do. So they can't be ignored, even if they're small or less worrisome. But we do know that for a subset of PNETs, the likelihood of spread is very low. And I just want to touch on this because this is an area of controversy. Some of the data for this really has evolved over the last 10 years. And I just want to show you a few quick studies. So, one of the earlier ones came out of the Mayo Clinic, and they looked at patients with tumors that were less than 4 centimeters in size. And this was a single hospital, very small series, but it got everybody talking because it seemed to suggest that small tumors did just as well as larger tumors if they had a resection or not. However, using even more restrictive criteria, a study out of Duke a few years later showed that patients that didn't have surgery had a 50% worse survival than patients that were observed. It's really hard to reconcile those two pieces of data. A study from our institution looked at very small neuroendocrine tumors in a national database study, and it showed that for very small tumors, those under a centimeter, 95% of patients were alive at 10 years, although some did develop lymph node spread and ultimately underwent surgery. So probably the best study came out of New York, where they looked at small tumors over 4 years, and this was a single institution, but a very well-controlled study. And basically what it told us is that for small tumors, the outcomes are the same if they're observed, but some of them will progress to needing a resection. So it's really important to watch. So the take-home point from a surgeon's standpoint, are there pancreatic neuroendocrine tumors that are safe to observe? Yes, but who are those candidates? So first off, like I said, they can't have any hormone hypersecretion. They've got to be asymptomatic. No evidence of lymph node spread, that very well differentiated or low-grade pathology, a small tumor, and then most importantly, they're amenable to follow-up, because we have seen patients that, because the follow-up has been lax, have progressed and ultimately have tumor spread that might have been resectable at one point and potentially curable. So what do we, for patients that do need surgery, that don't meet those criteria, what are our goals? So we want to maximize local control. What does that mean? We want to remove the lymph nodes around the pancreas, because we know that the lymph nodes are a frequent spot of early spread. Also, we want to get an R0 resection or one with negative margins, and we want to improve patients' quality of life if they're symptomatic. And of course, we want to minimize any complications from surgery. So how do we pick what operation to do? The tumor location is very important. Whether or not it needs the lymph nodes removed is also very important, and patient preference is also considered too. So enucleation is a technique that really just removes the tumor from the pancreas without removing much of the surrounding pancreatic tissue. Now, that sounds great, but not all pancreatic neuroendocrine tumors are amenable to this. Really, only very small or very benign behaving tumors like insulinomas are candidates for this. Most are not. And even for those type of reassuring tumors, if they're close to this pancreatic duct here, the complication rate goes very high if that duct is injured. So it's really a small number of patients that are candidates for it. And there's going to be some pictures now of some pathology and surgical cases. So there's the warning, but this is what it looks like after we perform the procedure. You can see the tumor there in the middle and just a little bits of normal pancreas around it. And this was an insulinoma, this particular case. Again, the number of patients that are candidates for that is quite small. If they're not candidates for enucleation, then the position of the tumor within the pancreas is really what leads to the decision. And the big deciding point is whether it's in the head of the pancreas, in which case a Whipple procedure, a pancreaticoduodenectomy is the procedure of choice, or the left side of the pancreas, where a distal pancreatectomy is the procedure of choice. And sometimes that includes a spleen removed along with it, and sometimes not. So just talking a little bit more about distal pancreatectomy, it's for a tumor, again, that's located in the body or tail of the pancreas. Sometimes it's performed open, but many times, in fact, the vast majority of the time today, especially at Yale, we can perform it in a minimally invasive fashion. If the spleen needs to be removed, it's a case-by-case decision, as I said, but if it does need to be removed, we can compensate for that lack of a spleen with vaccinations against a few of the organisms that the spleen helps with, so it doesn't affect one's life. Just a very quick video here. Oh, skip the video. Very quick video if I can make it work. Let's see here. I guess I can't. We'll try one more time. I think I have to go in here. Here we go. So this is a video of a laparoscopic distal pancreatectomy. What I'm doing here is elevating the stomach and getting into what's called the lesser sac. And you can see the tumor sitting right there with the white arrow pointed at it. The pancreas is running right and left on the bottom of the screen. So the first thing we do is mobilize and get that tumor elevated and completely get the pancreas lifted up there so we can see above and below it. And that in doing that, we can access the vessels that supply the pancreas and the spleen. In this case, you see me holding the splenic artery there, just about to come around it. That splenic artery supplies the spleen and the pancreas. It's divided with a vascular stapler. And then we fully mobilize the pancreas and divide it medial to where the tumor is. So we make sure we get that negative margin. And then once that's all done, we just pop it in a little plastic baggie and pull it out, and that's all there is to it. After the surgery, just switch back here. After the surgery, patients usually go home in about 3 or 4 days. Sorry. Losing control of my presentation here. Well, suffice to say, they go home in about 3 or 4 days if all is well. For a Whipple procedure, it's a bit more extensive. Most people are in the hospital about 5 or 6 days. And the reason it's more extensive is because the head of the pancreas, if the tumor is there, is unfortunately sharing a blood supply with all these other organs. So it is a bit more of an involved operation. But the remaining pancreas, the bile duct, and the stomach are all reconnected, and patients are able to eat and go about their lifestyle just as they did before the surgery once they recover. So a lot of patients ask me, is pancreatic surgery safe, especially the Whipple procedure? And in properly selected patients and properly selected institutions and surgeons, the answer is most definitely yes. So there's a very strong correlation between surgeon volume and also institutional volume for whether or not these procedures are safe. The reason that is, it's not just the surgeon, but it's the nurses, it's the radiologists, it's the ICU doctors. It's so that if there is a complication, it's recognized early, treated successfully, and the patient is still discharged with a great outcome. So just for some examples, before COVID, for 5 years at Yale, we were doing annually about 85 cases a year between the 4 surgeons that do them, which is an extremely high volume center. Just so you have some statistics, historically, the mortality for a Whipple procedure, the length of stay was very long and the complication rate was very high, which is why it's still a very daunting operation. But nowadays, especially at Yale, it's a very safe operation. And our outcomes in national databases are in the top 10 percentile of the nation. So just to summarize, like I said, the goals of the surgery are not just to control the disease, but improve the quality of life while minimizing the possibility for complications. There's those 3 major operations. And the choice of operation is largely dictated by where the tumor is, and the outcomes are excellent when done at high volume centers. Just switching gears for the last minute or two, I want to talk about enteric neuroendocrine tumors, those in the bowel. As Dr. Kunz alluded to, they can really arise anywhere. Just as an example, because it's one of the more common ones, we'll talk about those of the small intestine. It's actually been the most common tumor because of the incidental findings since 2000 in the small intestine. Only about 25 to 40% of patients present with symptoms. You can see some obstructed bowel here on the left with the tumor there, and this is something called an intussusception, where the bowel gets sort of inserted on itself, and it also creates discomfort obstruction. But most are diagnosed incidentally because there's a very high incidence of lymph nodes spread into the mesentery. And this mesentery is the structure where the blood vessels and lymph nodes run to the intestine. So what does that mean? We do the same kind of staging workup, but what we oftentimes see are these lymph nodes in the mesentery. And sometimes they're small like that, sometimes a little bigger, and sometimes quite large. And they can be involving some of these major blood vessels. So when we take patients to the OR for a small bowel neuroendocrine tumor, our goal is, again, to clear the primary tumor. But an important point is that many patients, up to a third, have multiple tumors. So if we use a minimally invasive approach, which we do when we can, we have to inspect the entire bowel. We also want to clear all those lymph nodes. And again, we want to minimize complications. So in the last few slides, just showing you, so when I talk about multifocality, here's a length of intestine, and here you can see 5 separate tumors in that length of intestine. So when we do the operation minimally invasively, we use some tricks like this sleeve here, this plastic sleeve, to allow us to take the bowel out of the body and inspect it with still very small incisions. And when there is mesenteric involvement on the major blood vessels like this, we sometimes have to do very careful dissections to remove a big portion of the mesentery while preserving those large arteries and veins. And here's just a few operative photographs. And then the last slide, I just want to talk about surgery and metastatic disease. So sometimes surgery is the right answer for a patient with metastatic disease. Generally, if the vast majority can be removed, or sometimes all of it can be removed. Again, this can sometimes be done laparoscopically. And we can do this through fairly small incisions. Here's that piece of liver after it's been resected. So just in closing, like I said, patients really need to be managed on an individual level because there's so much nuance. It's important to be at an experienced center. And the key considerations for the surgery is making sure all of the tumors and all the lymph nodes are removed. And carefully selected patients can still get a benefit even if there's metastatic disease. So last slide with just my partners in surgical oncology and our research staff. And I'll end it there and stick around for any questions at the very end. So I'll stop my sharing. And take
Dr. Kunstman, thanks so much. We're going to do questions all at the end. So Dr. Madoff will join. And I'll just remind everybody to please put questions in the Q&A. We're aiming for about 45 minutes total of some presentations, and then we'll leave plenty of time for questions. Thanks, Dr. Madoff.
Okay, so can you see my slides?
Yes, perfect.
Okay, great. So first, I'd like to thank you, Dr. Kunz, and the Center for GI Cancers at Smilow Cancer Hospital for inviting me to speak tonight on the topic of liver-directed therapies for neuroendocrine liver metastases. As you've already heard from both Drs. Kunz and Kunstman, there are now many surgical and medical options for this typically slow-growing group of diseases. So the reason why I am speaking tonight is that despite these advances, the literature, including this study from Dr. James Yao at the MD Anderson Cancer Center in Houston, and our own clinical experience, has shown that the poorest prognostic variable is involvement of tumors within the liver. Therefore, I'm here to introduce you to the field of interventional radiology, and even more specifically, interventional oncology, which has been used for a few decades in the armamentarium to treat patients with neuroendocrine liver metastases. Interventional oncology, or what we now call IO, is a subspecialty of radiology that utilizes minimally invasive image-guided procedures to diagnose and treat patients with various forms of cancer. The benefits of IO treatments are many. Our procedures are mostly done in the outpatient setting, are often done with moderate sedation or local anesthetic and without the need for general anesthesia. There is no surgical incision, and instead we operate through small pinholes, which usually leave no scar. The procedures usually result in immediate tumor death, are minimally invasive with being both cost and time effective, and hopefully lead to a gentle patient experience. Because they are done with image guidance, they are very accurate with a reduced risk of trauma to adjacent organs or structures, and have minimal side effects that often lead to an improved quality of life. And please note that interventional oncology is not radiation oncology. In fact, interventional oncology has now become the fourth pillar of oncology, joining medical, surgical, and radiation oncology. IO therapies are now incorporated into multiple NCCN guidelines. We are a valued participant in many tumor boards, and we offer clinical trials that can further define the role of these treatments in overall cancer care. So there are multiple ways that interventional oncology can get involved in the management of patients with neuroendocrine liver metastases, and includes diagnosis with percutaneous image-guided biopsy and treatments which include primary adjuvant and neoadjuvant tumor therapy, postoperative complication management, central venous access, palliation, and many others. So percutaneous image-guided biopsy is now the standard procedure for most non-palpable masses, allowing us to obtain diagnosis and precise histologic analysis. And this can therefore direct the modality and order of therapeutic options. And in fact, because of its utility, percutaneous biopsies are really one of the most important procedures that I do on a daily basis. So this is a relatively standard treatment algorithm for treating patients with advanced neuroendocrine tumors to the liver. IO's role is highlighted here in red. You can see that we become involved when there is a need for conversion to resectability, and when surgery is either contraindicated due to comorbidities, when the disease burden is highly complex or diffuse, and when patients are symptomatic and refractory to other medical types of treatment. So to clarify, we can convert patients to resectability by improving performance status and reducing the risk of postoperative failure. We can treat symptoms refractory to medical management and allow most patients to benefit from a sustained symptom-free interval. Lastly, we can try to influence patients with progressive disease burden, that is, palliate those with bulk-related symptoms or prevent those with marginal deterioration of liver function tests to progress to fulminant liver failure. So there are many types of liver-directed therapy. First, we see a procedure here called portal vein embolization, which has the main use of preoperatively growing the liver that will remain after a large surgery. Since the days of the ancient Greeks and the story of Prometheus, we have known that the liver regenerates. This procedure works by blocking most of the blood supply to the part of the liver to be removed and force the blood to the part of the liver that will remain. This will lead to liver growth and therefore can reduce the number of overall postoperative complications and increase the number of patients who are at risk for liver failure after surgery. Next, we have percutaneous ablation, which has the goal of eradicating all viable malignant cells while sparing normal surrounding tissues. We can treat tumors with unfavorable distribution patterns or locations for resection, and those with multiple comorbidities that are not able to have surgery. For neuroendocrine tumors, it is often used in patients with low volume disease and for debulking. There are many different types of ablation, ranging from heating, freezing, and electrocuting tumors. They all have nuances, so the physician performing the procedure will need to be aware of these. These procedures are typically done as outpatient and are repeatable, but they do often require general anesthesia. Lastly, we have transarterial therapy that is often used for unresectable tumors in patients with progressive disease or are symptomatic, or when liver involvement is at least 30%. It's also used for tumors in difficult or dangerous locations for resection or ablation. The rationale for a transarterial approach is that the tumoral blood supply largely derives from the hepatic artery, and that we can deliver intravascular agents via selective catheter positioning under fluoroscopy, and therefore minimize systemic complications and toxicities. There are currently three main categories of techniques, which I will discuss shortly. So the typical way transarterial procedures are done is through a tiny incision in the groin, and a skinny tuber catheter is advanced into the large artery in the abdomen, that's the aorta, and then snaked into the liver arterial supply. Various agents toxic to tumors are then administered to kill the tumors. And here we see early and late phases of an arteriogram with the circles or balls, all representing tumors that are filled with radiographic contrast dye. So there are four main types of transarterial therapies, and they are all shown here. TAE, or bland embolization, is the administration of small biochemically inert beads that destroy tumors solely by causing ischemia or lack of blood flow. Chemoembolization is divided into conventional and drug-eluting beads. Each uses chemotherapy administered via delivery vehicle, an oily substance known as lopiodol, or bland beads that have been soaked in chemotherapy and then elute the chemotherapy into the tumor. Lastly, there's radioembolization, whereby a radiation source, typically Y90 or yttrium-90, is attached to an inert particle and infused into the tumoral blood supply. So how does one decide which type of therapy you should receive? Well, it's based on a number of factors that include disease location and extent, such as diffuse or localized, as we see here. There are numerous procedural considerations, such as the advantages and disadvantages of each. There's tumor histology. There's also the expected outcomes, such as what we find with bland embolization working best for carcinoid, where chemoembolization actually works better for pancreatic neuroendocrine, and of course, patient preference. It's important for patients to understand that while we can advise and make recommendations, it's ultimately the patient's choice for what should be done. So what I wanted to just show in the next few minutes is just a few patient cases that highlight the liver-directed therapy. Here we see a neuroendocrine tumor patient with multiple tumors throughout the liver. The liver remnant was deemed too small, and we therefore performed a portal vein embolization. The left lateral liver, which we can see here, grew, and the patient therefore underwent a successful major liver resection with an uneventful postoperative course. Here we have a patient with a carcinoid syndrome caused by this small tumor indicated by the arrow. This tumor was in a very difficult location, and due to the carcinoid syndrome, had too poor a nutritional status to undergo surgery. I embolized the tumor. The tumor got smaller and the symptoms resolved. She ultimately gained 30 pounds, and the patient was therefore able to undergo the uneventful surgery. Here we see a small tumor indicated by the white arrow, but the tumor was symptomatic, as shown in the right liver. I used ultrasound guidance to place the probe into the mass and used microwave ablation to heat and kill the tumor, and 18 months later, this patient had no recurrence. This is another case of a patient with carcinoid syndrome who underwent bland embolization, again with inactive beads. After 4 rounds of therapy, you can see that on the right, the tumors are much smaller and much less easy to see, and she therefore became symptom-free. Here we have a woman with extremely rapidly progressive rectal neuroendocrine tumor despite systemic therapy. In fact, her tumors were growing out of control in a very short period of time, and we were able to treat these tumors in all areas of her liver with multiple rounds of chemoembolization. Here we see massive necrosis of the tumors in the right liver. Fortunately, we were able to stop the progression and even shrink the tumors, and she's doing very well. And lastly, this is a patient with carcinoid who had diffuse tumors with treated with radioembolization. We can see the numerous tumors on the right liver and the scan, the Bremsstrahlung scan shown here, which shows the radio embolization particles within the right liver. And this patient was treated with in both lobes and ultimately had stable disease noted to be after 1 year. So before I finish, I just wanted to bring to your attention the RETNET clinical trial. This is a study that's looking to compare the outcomes of bland embolization and chemoembolization, although the drug-eluting bead part of the chemoembolization arm has been stopped due to higher toxicity than had been previously expected. So in conclusion, neuroendocrine tumor liver metastases therapies should be individually tailored, and fortunately, there are many cytoreductive options to help with survival and palliation. Each therapeutic modality discussed does have advantages and disadvantages, but given the limited time, I was not able to go into much detail. Clearly, it takes a high level of expertise and considerable experience to ensure good outcomes. However, if you do need such a treatment option, you should discuss in detail with your family and physicians which therapy may be best for you and suitable for your circumstance. And thank you for your attention.
Thank you, Dr. Madoff. That was great. We will move now to Dr. Pucar, and then Dr. Aboian will follow.
Can you all see my screen?
Yes, Darko, that's great.
Great. So good evening, everyone. Thank you for attending this session, and also thank you, Dr. Kunz and Smilow, for organizing the session. I will briefly discuss imaging, focusing on the dot-to-dot scan. And actually, the quality of imaging does matter because many of these tumors are small and we want to do our best really to detect them and also to look for their changes. So if you're diagnosed with neuroendocrine tumors, the main scan that you will be receiving is either CT or MRI of the abdomen and pelvis. And as you have seen in prior imaging that has been shown, they are very well seen, but that's only because a special protocol was applied so these otherwise subtle tumors can be well seen. When it comes to the dot-to-dot PET, you probably heard that there are two options, one with a gallium and other with copper, but don't worry, they are actually performing very well clinically, both of them, and they have replaced prior octreoscan. And really these days, you shouldn't be getting any more deoctreotide scans because dot-to-dot is so much better. However, dot-to-dot is only complementary to CT and MRI, and it should be used at critical junctions in your management. There is another type of the scan, which is with the glucose, which you probably heard because that's like a main PET scan. It's not used commonly in neuroendocrine tumors because fortunately tumors are less aggressive and don't take much of FDG. But if we occasionally suspect a more aggressive tumor that is faster growing or so-called neuroendocrine carcinoma, which is more aggressive than typical neuroendocrine tumors, we may actually use FDG scans. So this is a picture of our Siemens scanner at Yale New Haven Hospital. And I got the picture with two of my technologists. And as you will see, our technologies are great. They are very friendly and you would enjoy your visits with them. And don't worry, I mean, it's not really scary. I mean, yes, for very claustrophobic patients, it could be a challenge, but most patients actually do very well with the scans. The scans are available from Monday to Friday, and it takes about 25 to 40 minutes to perform. There are some small differences between the tracers and also depends on your height. Obviously, if you're taller, it will take a little bit more to do it. So this is an example of a normal dot-to-dot scan. And as you can see, most of the activity is kind of in the abdomen, but you would also see normal pituitary, normal salivary glands. And then in the abdomen, you will see normal liver, spleen, kidneys. There will be activity in the bowel, and some tracer will be excreted in the bladder. And the tracer is actually targeting so-called somatostatin peptide receptors in the body. And you will actually hear about these in all the lectures a little bit from all the speakers. And as you can see, the challenge is that neuroendocrine tumors and the normal activities are kind of most frequent in this abdominal area. It can be busy. So that is why we use so-called cross-sectional imaging, where we are fusing the activity from dot-to-dot with a CAT scan, so we can localize precisely both normal structures and the tumor. And I just want to mention something for your knowledge, is that pancreas and bowel, where usually these tumors originate, have a normal variable activity, and sometimes it can be confusing. So generally, if someone suspects the tumor on the dot-to-dot scan, it would require either CT or MRI validation, or occasionally an endoscopy would be performed. But you cannot just use dot-to-dot alone without validating with CT and MRI. So this is an example of a metastatic well-differentiated neuroendocrine tumors, and these are tumors that avidly take dot-to-dot, and they usually have activity more than normal liver. So you here see metastatic disease in the liver with a blue arrow, and you see how the activity is above the normal liver. And some of them can be as high to have activity above normal spleen. And we have some scoring system that actually uses liver and spleen to actually classify the avidity of these tumors. And as you can see, it's amazingly sensitive because this was actually very, very tiny primary in the pancreas that later on metastasized in the liver, as you can see with the blue arrow, and to the abdominal cavity, as you can see with the green arrow. And the advantage of dotted scan is that sometimes can detect either disease either in areas that are not covered with the standard CAT scan or MRI, or sometimes the lesions that are not visible with standard CAT scan and MRI. Not commonly, but if you have a large practice like at Yale for neuroendocrine tumors, you will see a fair number of people that have tumors in addition to Yale, to the liver and abdominal cavity, also in the skeleton. And this is where a dotted is particularly valuable because it will be very difficult to scan the entire body with the CT or MRI, and moreover, dotted is also frequently more sensitive than this modality, is particularly more sensitive than CT. So if you have disease that is in the bone, you may actually be scanned more frequently with dotted. Usually you get dotted scans every 1 to 2 years, but you can get more frequent dotted scan if you have a skeletal disease, especially if someone suspects the progression in the areas that are not covered by CT or MRI. Now, imaging interpretation is complicated, and really expertise and of your readers do matter. And fortunately at Yale, all of us see a lot of these scans, and we have a lengthy experience in interpreting those scans. So one thing which I would also have to mention to you when you are reading your report, report is only the first step. The final decision on the response or progression is not made by radiologist. It is made by your oncologist. So you usually don't get alarmed with your report until you actually speak with your oncologist, which would put those findings in way better context for you. And one thing which also is important to mention so you don't get alarmed, neuroendocrine tumors are chronic disease with which you would live for decades. So minor responses or minor progressions may not be clinically significant to justify the management change. So if someone describes some new small lesion, that may not actually be serious or require the management change. Size measurements are validated on CT and MRI, but not on dotted. So in order for look to the size changes, you would have to stay with your main modality. And one thing which everyone gets cares about is SUV changes. So that's a unit that we use to express activity on PET scans. But for neuroendocrine tumors and dotted, these are not really clinically relevant. So increase in SUVs does not mean progression, and decrease in SUVs does not mean response. And a little bit about the logistics. So again, your main modality would be either CAT scan or MRI, depending on the preference of your oncologist. And for patients with metastatic neuroendocrine tumors on treatment, they are usually recommended every 3 to 6 months to look for changes in tumor size. If you have surgery, and especially if they were able to remove most of the tumor, all of the tumors, the scan would be performed a little bit less frequent, usually at 6 to 12 months, to monitor for recurrence. Dotted PET scans are usually performed at diagnosis to determine the tumor spread, or what would be the medical terms staging that Dr. Kunz spoke about. And then every 1 to 2 years to look for areas of progression not detected by CAT scan or MRI of the abdomen and pelvis. And prior to Lutathera treatment, which has revolutionized the field that Dr. Aboian will talk to you about. And occasionally, rare patients with aggressive disease would receive FDG PET scans. And that would be that would be like a brief overview of the imaging. Thank you.
Dr. Pucar, thank you. We will end up with Dr. Aboian, and then we'll open up for questions.
Can someone stop my share? For some reason, I have a hard time stopping. Oh, okay, I was able.
Okay,
Thank you.
great. Thanks. Take your time. I'll remind everybody to please keep putting your questions in the Q&A, and we're trying to answer them as they come in, and we'll address some of them also at the end. Perfect, Mariam. That looks great.
Thank you. Thank you so much. And thank you all the speakers for fantastic presentations, and particularly Dr. Pucar for great overview of the imaging of neuroendocrine tumors. And I will address really quickly in terms of what is theranostics. When we think about imaging, we think about CAT scans and MRI scans, and a lot of the times we are seeing just anatomy. We see the liver, the vertebral body, the spleen, the stomach, the subcutaneous fat. That's what we see and how we interpret. We can also see a little bit in terms of where the tumor is. So here's a couple of tumors in the liver. But we want to start seeing with nuclear medicine, and this is what was really exciting about Dr. Pucar's presentation, is to see beyond anatomy and to see into the function. So nuclear medicine allows us to do that. So here's an example of just seeing the anatomy and seeing the just basic imaging characteristics of the tumor. But we want to start heading towards this. Now you're looking at this right now and you're saying, well, actually this image doesn't look that good. It's kind of hard to see what's going on. I'm not even sure where the liver is here. And if you think about it, each cancer cell here is holding a light bulb, and this light bulb is sending a signal. Hey, I am a very specific looking cell. And that's what you're seeing here. You actually see tumors here that are in this particular patient. You also see some splenic uptake and some normal tissue uptake, but not so much. Majority of the signal comes from tumors. And if you look at the corresponding to CT, you can see that these tumors are not as easily seen without this fantastic agent called gallium dotatate, as Dr. Pucar discussed just now. But what does that mean? What is this gallium dotatate? I know some of the students sometimes when they rotate with me, they say, Dota, what? What is this DOTA tracer? Well, it turns out gallium dotatate will dissect it point by point, but it really allows us to visualize cell surface of the tumor and the receptors on that cell surface. And the way it's able to visualize it is by the ligand that binds to the receptor. And because the ligand is radioactive, it lights up like a light bulb. And the reason why it lights up only on tumors is exactly how Dr. Kunz described the lock and key idea. So the receptor, you can think of it as a lock, and the ligand, you can think of it as a key, and as a very specific interaction between the ligand and the receptor. So when you're giving this radioactive drug, it goes specifically to the cells that have this receptor and targets those cancer cells that are holding up this light bulb and saying, hey, we're here. And that's how you're able to specifically target the therapy to this location. how do we give the radioactive nuclide? Well, actually, we want to be extremely safe, so we put it in a cage. And it's a chemical cage, but you could think of it as a cage right here. So the radionuclide is located in the cage, and then we attach the key to it that will take it directly to the cancer cell. So this key takes this payload with it to destroy the cancer cells. So let's dissect what this means. So the radionuclide you see right here, can be, you can pick any radionuclide. It could be the imaging radionuclide, or it can be a therapy radionuclide. But here we're talking about the imaging, so gallium or copper. And then the cage is DOTA. So that's what DOTA means. It literally is just a cage, and it's ubiquitous. You can use the same cage for different radionuclides. And then Tate is actually the targeting molecule, the key. And when you combine them all, you get this payload, and it goes into the body and directly finds these specific receptors and connects with the lock. So then you have the lock and key. And thus you are able to really target specific cells. And the way we call it is gallium, DOTA, Tate. So radionuclide, cage, and the key. That's basically how it works. Now, how does the therapy work? Well, the cage and the key are the same, but the radionuclide is different. So the radionuclide could be lutetium, actinium, or bismuth. And we're working on these kinds of therapies at Yale to start bringing you these kinds of therapies so that we can provide the best care for you. And then the cage stays the same, and the targeting molecule stays the same, the Tate. So with this method, you can actually image the patient with the same drug, then exchange the radionuclide from the cage for the treating drug, and treat the patient with the same drug. So you're basically providing very targeted therapy. And then the therapy will go straight to the somatostatin receptor, and we will call it very similarly lutetium, so the radionuclide, DOTA, the cage, and Tate, which is the targeting molecule or the key. And this is the basis for image-guided therapy, or as we know, theranostics. We do the imaging with the imaging agent, the gallium, DOTA, Tate, and then you can see all the tumors are lighting up throughout the body because they have this receptor, and the cells are holding up the light bulb and saying, here we are, we're right here, we're expressing this receptor. Then we give the therapy with lutetium dotatate, which is identical drug as the gallium dotatate, except the only thing that's different is the radionuclide. This is our imaging nuclide, and this is our treatment radionuclide. And then we can actually do post-treatment imaging, and we can see exactly where the drug went, which tumors the drug went to, and we can even estimate the dose that the individual tumors obtained. And then we can send them to the interventional oncology and surgery for targeted therapy, as was greatly discussed earlier. So this therapy approach is actually not very novel, but the approach to neuroendocrine tumors is very novel. And this therapy allows us to pick the right patient and use the right drug for the patient. Now, the concept of targeted therapy has been available for a very long time. And the idea for targeted therapy is to treat cancer by targeting proteins and pathways that control how cancer cells grow and divide and spread. But when you give a drug that targets a specific pathway or specific protein, there's no way you can target it to a specific tumor cell. With theranostics, we're actually are able to image the targets and make sure that the patient's tumors are expressing the targets that we're planning to attack, and then target the therapy, and then see where the drug went and calculate the dose the tumor received. That is the advantage of theranostics, and it's the next kind of like the targeted therapy 2.0. You can think of it that way. Now, it's actually a very developing field right now, and you can see that over the last several years, there's been a lot of advances in imaging of neuroendocrine tumors and therapy of neuroendocrine tumors with different agents being FDA approved. But it's not just neuroendocrine tumors. We're also, the field is also developing therapies for prostate cancer, for breast cancer, and imaging agents as well. So this is an emerging field, and we're jumping on this field at Yale by building a theranostics group here as well. Many of you have may have already read this article. This is the seminal work that came out of the NETA-1 trial, which is a phase 3 trial of lutetium dotatate for midgut neuroendocrine tumors. And it led to FDA approval of the lutetium dotatate, or as it's also known, Lutathera. The reason why it was approved was on the basis of prolonged progression-free survival. And about 18% of the patient had significant tumor shrinkage. The treatment with Lutathera is actually very well tolerated by most, with very few serious side effects. And the way this works is the principle of peptide receptor radionuclide therapy, or as you all know it as PRRT. When you inject the drug into the vein, it travels throughout the body, but then concentrates around the neuroendocrine tumor sites because the neuroendocrine tumors express the somatostatin receptors. Once these drugs are, once lutetium dotatate binds to the somatostatin receptors, the receptors get internalized or endocytosed. Inside of the cell, the lutetium is able to emit beta particles and result in DNA damage, which can cause tumor cell death. And that can actually cause some reduction in tumor volume or prevention of growth. So in conclusion, theranostics integrates diagnosis and therapy in a single platform. It allows to select right drug for the right patient. Lutathera, as a lot of you know, is an FDA-approved drug for neuroendocrine tumors and has been shown to prolong progression-free survival. And here at Yale, we're dedicated to develop and bring future theranostics to help patients like you and really advance the field so that we have better therapies.
Thank you, Dr. Aboian. So great presentations. I really want to thank everybody, all of our speakers for their time and explaining things. And I hope for our audience that gave a nice overview of the state of both kind of what exciting advances we've seen in the last decade and really kind of some practical tips on understanding your net and on treatment options. So we've been trying to answer some of the questions in the chat. I may select a few of those as we go through our Q&A. So this is the time. Please feel free to ask your questions. I'm going to start with just a few general ones, and I'm going to start with Dr. Kunstman. So we talk a lot about the importance of multidisciplinary care for patients with neuroendocrine tumors. Can you describe what a tumor board is for our audience and how we talk about taking care of patients?
Sure. A tumor board is a little bit of a misnomer because it's really a board of a lot of people that treat tumors to discuss patients. But essentially, it's a group not unlike the one you see before us, but much larger, including possibly many surgeons, many medical oncologists, many radiologists, pathologists, interventional oncologists, et cetera, all of which are involved in treating a particular tumor type, site, or location. Just as an example, at Yale, we have a tumor board that specializes in neuroendocrine and related GI cancers that meets weekly. And sometimes, it's just a matter of a provider really wanting to find out if anybody else has any other ideas or about a change in therapy. Other times, it's really an open conversation. But I think it's critical because obviously, we're all very specialized in what we do, and there may be things that one of us doesn't know, and it's actually critical. I think we've all said in the refrain from tonight, that you're really treated by a group. You're not treated by an individual. The tumor board process is a critical part about that.
Yeah, thank you. That's perfect. It includes our nuclear medicine physicians, our interventional radiologists, all of the people on here are part of that tumor board. So Dr. Madoff, I have a question for you about liver-directed therapy. So often, either myself or even a tumor board will identify a patient that may be appropriate for liver-directed therapy. There are a number to choose from. I don't pick what I generally refer patients to. I let you and your team really help pick which may be the optimal treatment for the patient. Can you walk us through a little bit what goes into your mind about selecting between some of the available treatments that you mentioned?
Yeah, so that's a great question. That is, a very difficult question, because unfortunately at this time, and this is what the RETNet trial is supposed to figure out, is what is the best treatment for any particular disease. So like I had mentioned, when patients have very low volume disease, if they have very small tumors in very, what I would consider non-challenging locations, which means, for example, that if it's in the liver and it's small, maybe 1 centimeter, it's not near any major arteries or veins or bile ducts, it should be easily treated with ablation. That being said, there are a lot of challenges where tumors are sitting in a really difficult location and either would be surgical candidates, could even be potentially, I guess, and they're not here tonight, but radiation oncology patients, but are right on a very difficult structure. So in those cases, I probably would choose embolotherapy. Now, between the or the embolization therapies, there's a lot of nuances. And like I said, I haven't had really a chance to get into all the details of them. But, for neuroendocrine, where we know that patients live pretty long and hopefully prosperous lives, you have to also consider what's going on in the normal underlying liver. It's not simply the tumors, but it's also what is what you will be living with, because technically the tumors themselves are not, even though they could be functional, they're not functioning as normal liver cells. So you only have so many liver cells. So you have to worry about the I guess the collateral damage. Okay, so I know there's been a lot of interest in, for example, radioembolization. Radioembolization is, as we discussed, an outpatient therapy. It is because it gives radiation and not causes ischemia. It doesn't typically result in a lot of pain. So the tumors themselves can, and it's also guided by vascularity. So these neuroendocrine tumors, as I showed, are really hypervascular, meaning that they suck up treatment in a very big way. But when you're young, you're in your 40s, and you have a therapy, or you need a therapy, I pretty much try not to give radiation, because there's only so many times you can give the radiation. I would say that it's not repeatable in the same way an ablation or another type of embolization is. So these thoughts always go through my head when I'm speaking to a patient. And what we didn't say is that part of interventional oncology is, even though we're radiologists, we see patients the same way that Dr. Kunstman or Dr. Kunz see them. So I have my own clinic. It's not the way interventional radiology used to be practiced, but in the 21st century and now 2021, we do formal consultations, go through the images, walk patients through the different types of scenarios, and it's actually very, I must say, enjoyable.
Great, thanks so much.
I hope that answered your question.
Yeah, that was super helpful. I mean, I think hopefully the audience can get a sense, and I think one of the real keys takeaways from tonight is that we really try tailoring the treatment to an individual patient. So one size does not fit all. There are some general principles for how we treat patients with NETs, but we really do tailor the treatment, and many of those decisions are made at our tumor boards. So I have a question for Dr. Pucar. It was asked in the Q&A, but I'm going to ask it just broadly so everyone can see the answer. So this is really around like thinking about, can you speak about examples of the dotatate showing lesions that are false positive? You know, and I think that was really important as we were learning to read these scans. I think that at expert centers, we're very familiar with what is false positive. Can you speak to that a little bit, Darko?
Yeah, that's always a concern with any scan, regardless whether it's a nuclear medicine scan or an anatomic scan, because imaging is usually very, very helpful to find things. But really the specificity sometimes comes from imaging, but usually for at least in the cancer world requires tissue confirmation. So on dotatate specifically, the concerns are, for example, that inflammatory conditions can mimic neuroendocrine tumors. And also there is a concern that other cancer in the body can take dotatate and again create the confusion. Now we have a so-called Kreinig scale, which basically classifies whether they are more active than liver, but less active the spleen, which should be called Kreinig 3, and then the lesions that are more active than liver would be Kreinig 4. So with the lesions of Kreinig 3 and Kreinig 4, we have a way more confidence that they are actually neuroendocrine tumors. But again, at any critical juncture for the treatment, tissue confirmation would still be the gold standard. And I think we have one good question. I'm just going to try to make it a little bit more broad. So basically, if someone has pancreatic head lesions, which endoscopic ultrasound couldn't confirm, what would be the option? I can start that we can, for example, do dotatate scan and to demonstrate high activity above liver or spleen to increase the confidence. But we actually need a tissue to determine Ki-67 and differentiation to guide the management. So I'm going to leave to our panel members to see how they would approach that situation.
Yeah, I completely agree. And in fact, I think I might have answered that question, but yes, I totally agree with that. I might turn to Dr. Aboian and just ask a little bit about, this peptide receptor radiotherapy that I think has really been a major advance in the landscape of patients with NETs. Can you talk us through the day of a treatment? Like what happens when patients come in to get this treatment? I think there's a lot of fear because it's a form of radiation, but most of my patients, I'll tell you, come back and say to me, Doc, that was a lot easier than I thought it was going to be. But maybe I'll let you walk us through what the treatment is like.
Oh, sure. Thank you so much for a great question. So the day of treatment is actually pretty straightforward. When we just started with PRT, it used to be a much longer day, and but now we have much more advanced amino acid solutions. So the experience is much easier. We have a really nice therapy room on the 8th floor of the Smilow hospital, and basically you get a nice view, and you stay in the room. The room is nicely protected and is lined with protective paper and also chucks to. And I'm sorry, I should have included a picture of that. That would have been really nice, but you kind of will see everything is protected because we don't want any drops of radioactivity anywhere. You will receive your amino acid infusion, and usually you're in a comfortable bed, and then we will stop by and chat with you about the therapy and about how we will administer the therapy and discuss the side effects and the precautions for after the therapy. And then we'll administer the therapy, which doesn't take very long. It's usually on an order of like 30 minutes and via an IV. And then after that, the amino acid infusion will continue, and you will be discharged. So it's a pretty straightforward process. It's not very exciting, but that's how we like to keep it. And then we'll spend a lot of time just chatting during the infusion. So.
Thank you. Yeah, and just to follow up on that, so the amino acid infusion for everybody is to help protect the kidneys. This was sort of started like decades ago when this therapy was originated in Europe, and it originally used a combination of amino acids that caused quite a bit of nausea. It now only uses 2 amino acids called arginine and lysine. Those tend to not cause as much nausea, so it's a much better tolerated. In total, it's about a 4 to 6 hour kind of infusion, and it's given every 2 months for a total of 4 doses is really the standard course, just to give folks a sense of that. So thanks, Mariam. I'm going to go back to the Q&A and try to answer a few questions. So one, I will try answering. So does your clinic have a specific approach to sequencing order of treatments, especially for well-differentiated grade 3 neuroendocrine tumors? So I'll mention that this is a relatively new category. As I'd mentioned in my talk, neuroendocrine tumors are broken up into these 3 main buckets: grade 1, grade 2, and grade 3. Also by degree of differentiation. So well-differentiated tumors tend to look more like the normal cells in that organ, and poorly differentiated tumors tend to look very different and kind of disorganized cells, different than the primary organ. And so well-differentiated generally means that it's slower growing, but grade 3 is in the faster growing bucket. So I tell patients we usually borrow from both treatment buckets. We worry that these may be a little bit faster growing, but we can often use therapies that are reserved for the slower growing tumors. And the question is a great one. And actually this answer generally applies to all NETs. We don't have clinical trials or data that helps guide what order in which to give these treatments. We are in a fortunate place right now to have a number of therapies, but we don't yet know which one we should start with necessarily. And this is where we then really tailor the approach to a given patient. So for example, if someone is having symptoms, i.e. pain from spots in the liver or pain from somewhere else, maybe we need to use something that shrinks the cancer. If someone is having symptoms from hormone secretion, we maybe need to use a therapy that helps lower those hormone levels. So all of these things are discussed with this entire treatment team, and we help come up with the best plan. I'm going to answer or ask another question and see if anyone from the group wants to try to answer this. So how common is it for NETs to be a precursor for other forms of cancer, for example, bladder cancer or lymphoma? Dr. Kunstman, do you feel like tackling that one?
Yeah, I mean, I think that's actually a very good question, because whenever we talk about cancers that can have a more indolent course, such as neuroendocrine tumors, it naturally creates a question in your mind, is it leading to something more aggressive? Now, in the case of bladder cancer or lymphoma or colon cancer, or et cetera, now those are totally distinct entities, and neuroendocrine tumors are not precursors per se to other forms of cancer. So the answer to that question is no, but certainly we do see the differentiation status and the grade sometimes evolve over time, and a previously indolent neuroendocrine tumor can become more aggressive. That's why I think there was one other question in the chat box about, a diagnosis, and once removed, what's the next steps? That's why surveillance and really a long-term relationship with your neuroendocrine team is so critical, to sort of find out about those changes as soon as possible, and whether, the way to mitigate it is with a therapy.
Yep, great. Thank you. Well, we have about 10 minutes left, and I am going to end by going around and asking all of our panelists what they are most hopeful about in the field of neuroendocrine tumors, where you hope to see the field go, specifically what you do. I'm going to start with Dr. Madoff. Sorry to put you on the spot.
This is a hard one, because as we discussed, I mean, interventional radiology, interventional oncology has been actually at the forefront for like maybe close to 4 decades. I used to work at MD Anderson in Houston, and we had some of the pioneering work on embolotherapy for carcinoid and the like. So what I think would be great, and I guess Mariam had kind of alluded to, is how interventional radiology or interventional oncology could play a role in theranostics. There's been talk years ago about nanomedicine, and the idea was that you have this nanotechnology that then gets to the exact target. However, it's been found that most of the material injected never actually makes it to the target. So you have a lot of stuff going to the target, but you don't actually, but most of it degrades in advance. So with imaging and imaging guidance, we could localize these kinds of therapies to the tumor itself without having to go through all the other circulatory issues. And in that way, we'd be able to get a much better, and like we talked about, targeted therapy.
Great, thank you. Maybe I'll pass to Dr. Aboian next.
Thank you. I went into nuclear medicine when I saw PRRT as I was training at UCSF, and I was just blown away by these amazing therapies. But I just remember watching the tumors after PRRT, and majority of the patients did not have the tumor shrink. Yes, they had improved progression-free survival, but the tumors were not shrinking as much as I would like to. So we have a fantastic key, but I really want that radionuclide that will make them shrink. So I think that's where we're going to be heading to, and testing the radionuclides that can potentially make these tumors shrink. And also, of course, work with Dr. Madoff and Dr. Pucar and Dr. Kunz and Dr. Kunstman for building our theranostics center. So
Great, thanks, Mariam. Yes, I'm excited about that too. So Dr. Pucar, what are you most hopeful about?
Well, short term, obviously, we need to develop our theranostic centers, because we actually expect explosion of these therapies, both for neuroendocrine tumors, but also for the other cancers. There are a lot of exciting agents coming. Now, in terms on more scientific level, probably the goal for neuroendocrine tumors is to basically have that turn into real chronic disease that doesn't shorten the lifespan and doesn't produce morbidity. So one of the things on the imaging side, it would be good for us to develop a little bit different imaging criteria, which would not lead us to change or do therapies too frequently before actually the other prior therapy is not really stopping working, which I think we'll probably have to make a criteria that is specific to neuroendocrine tumors, because other cancers are more aggressive, and those criteria probably are too aggressive for neuroendocrine purposes. And then obviously, which everyone is alluding, I mean, in theory, if you can minimize the toxicity to surrounding tissue, you can actually theoretically deliver the dose that would eliminate all your cancers from your body. No one that ever reached so far, because toxicity to the normal tissue was always too limiting. But there is at least that theoretical goal. And just to mention along those lines, we'll be getting probably by the end of the next year a machine which is called Reflection, which can use PET guidance to eliminate a lot of metastatic sites with radiation, which is going to add another excellent way to minimize your tumors and really enable you to live a long and prosperous life without neuroendocrine tumors defining you, but rather you living your normal life.
Thank you. Dr. Kunstman, any final thoughts? Things you're hopeful for?
Yeah, I have to say, actually, the thing I'm hopeful for is the other people on this call, because, as I think let me explain what I mean by that. So as I think you may have gathered, some of the surgeries that we do are technically quite complex, but there's a limit to what we can do in the operating room in terms of who's a candidate for surgery. And through the work, both from a diagnostic standpoint, a theranostic standpoint, and right now, I think Dr. Madoff alluded to some of his techniques. We're operating on and potentially curing people that would have never been candidates for surgery just a few years ago. When I was in medical school and I was starting the journey to becoming a surgical oncologist, people were saying, well, by the time you finish your training, cancer, it's all going to be figured out. You're not going to need anything. You're not going to have anything to do. In reality, we're busier than ever because patients that previously were basically told, we can only offer you best supportive care, potentially through portal vein embolization, we can resect that liver tumor, potentially through, PET dotatate, we can identify that last reservoir of disease and take it out. So it's a really, really exciting time, I think. And surgery is like the only field in medicine that's actively working towards its own obsolescence. But I'm more excited than ever because there's so many folks that we're able to help now that perhaps in the very recent past didn't necessarily have those kind of options. So it's a time of really great excitement.
Great, thank you. No, I share the hope on this call mentioned by all of the speakers, and I think I've been in this field now for about 12 years, and I think, over the course of that time, I've taken care of some patients for that entire duration of time, and they, in their lifetimes, have benefited from clinical advances through clinical trials. So I think I'm really hopeful about these advances also. So I just want to thank the speakers so much for their time tonight. I want to thank the audience for your listening and participation. This whole talk will be available online, so you can go back to it. You can share with your friends and family. We're certainly available for questions and or consultations, but thanks. We're excited to really build the NET community at Yale. So thanks, everybody.